Hi, everyone. Welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be unpacking the topic of acquired heart disease and CHD. We're very excited to be joined by today's guest, Dr. Markus Schwerzmann. Dr. Markus Schwerzmann is a cardiologist at the University of Ottawa Heart Institute and an associate professor in the Faculty of Medicine at the University of Ottawa. He earned his medical degree from the University of Zurich in 1996 and subsequently trained in internal medicine and cardiology in Switzerland, followed by a fellowship in adult congenital heart disease in Toronto. Prior to his training in ACHD, he completed a research fellowship in echocardiography at the University Hospital of Bern and worked as an attending physician in the echo lab. He was certified as a Swiss specialist in internal medicine in 2002 and in cardiology in 2006. After his ACHD training, Dr. Schwerzmann founded and directed the Adult Congenital Heart Disease Unit and co-directed the Pulmonary Arterial Hypertension Program at the University Hospital of Bern. For many years, he was a board member of the European Society of Cardiology Working Group for Grown-Up Congenital Heart Disease and one of the co-authors of the 2020 ESC guidelines on ACHD. He was also the coordinating reviewer of the 2022 European Society of Cardiology and European Respiratory Society guidelines on the management of pulmonary arterial hypertension. He served as the president of the Swiss Society for Pulmonary Hypertension until his move to Ottawa. He is a member of the Swiss Society of Cardiology, the Swiss Society for Pulmonary Hypertension, the International Society for Adult Congenital Heart Disease, and is also a fellow of the European Society of Cardiology. Dr. Schwerzmann joined the University of Ottawa Heart Institute in 2023 as the lead of the Adult Congenital Heart Disease program. His research interests include the transition process, as well as care perspectives when approaching end of life, and the identification of outcome predictors in ACHD. Please join me in welcoming Dr. Markus Schwerzmann. Hi, Dr. Schwerzmann. Welcome to CHD Unpacked. Thank you so much for being here today.
Thanks a lot for your invitation. It's a pleasure to be here.
Great. So can you tell us a little bit about the scope of your practice?
Well, I'm an ACHD cardiologist, and maybe as you can hear from my accent, I'm not Canadian. I'm from Switzerland, and I moved last year in May. I moved from Bern, Switzerland, to Ottawa, and now I'm part of the ACH team here in Ottawa, taking care of the ACHD patients in the capital. My background is I'm an adult cardiologist, and I trained about 20 years ago in Toronto with Dr. Webb at that point in time in ACHD. Then I went back to Switzerland, and now I work there for about 17, 18 years, and now I'm back in Canada. And yeah, I'm looking forward to take care of the ACHD patients here in Ottawa and also in the surroundings.
Well, we're happy to have you here, so thank you so much. Just to start off the episode, we're going to be talking today about acquired cardiovascular disease and CHD. So can you give a brief overview of what acquired cardiovascular disease is?
Yeah, as I said, because I'm an adult cardiologist and I'm not always only caring for ACHD patients, I see also adults having cardiac problems independent of a cardiac defect, and these are usually the problems you get when you get older. And this means when you get older, you're more at risk of having a heart attack, of having a stroke, or having valve problems just related to the degeneration of your valves. And also a heart attack is just a consequence of more calcification of your vessels, and the stroke is the same. So acquired heart disease is actually the burden of cardiac problems related to aging.
Thank you for giving us that definition so we can kind of keep that in mind for the rest of the discussion. So is there any evidence in the literature to suggest that adults with congenital heart disease are at a higher risk of acquiring cardiovascular disease as well?
Yeah, I think now with the experiences from the past decades and having more and more adults with congenital heart disease really getting old, this means getting in their 60s, 70s, 80s, we see that they also suffer myocardial infarction, that they suffer stroke. And we realize that some patients with some specific defects even are at higher risk of having a stroke or having a heart attack at one point in time when they age. And so we realize that now, being as an adult in the second part of your life, it's not just the burden of the cardiac defect, of the congenital defect that counts, it's also what happens to your heart and to your vessel just by aging. And so we realize that we have to focus our attention not just of getting you through adolescence and young adult age and middle age, but now we have to guide you also through the second part of your life. And then in this part, acquired heart disease becomes more and more important.
For sure. And you mentioned that there's certain congenital defects that would put someone at an increased risk. Could you give some examples of some that might come to mind?
Yeah, I think let's say the traditional risk factors for having cardiac problems with aging, I think the ones most of you may be familiar with, it's having a high blood pressure, having diabetes, a high blood sugar, having family history or smoking. And so for many of these defects, yeah, we cannot control. But hypertension, for example, high blood pressure is one defect that for some congenital lesions like coarctation, even if coarctation patients have an excellent repair and doing fine, they are still at higher risk of developing high blood pressure at one point in time. And this high blood pressure at a later stage translates also into a higher risk of having a heart attack or having a stroke. And then we have other lesions, like, for example, transposition of the great arteries. These children underwent surgical repair in childhood, and part of the repair was that also the coronary arteries had to be switched from one vessel to the other vessel. Mm-hmm. And we believe that this kind of surgery at the coronary arteries, even it doesn't produce any obvious damage, but also make these vessels more prone or more vulnerable to other lesions once you're getting older. And this usually doesn't manifest at 10 or 20 years of age, but maybe it manifests after 40, 50 years of having lived with this kind of defect. And so we're seeing that we have more and more ACHD patients who are, once they're getting older, having cardiac problems actually out of proportion to what we see in the general population.
Okay. And given that this is the case, do you generally start to screen for some of the risk factors for acquired heart disease earlier in someone who has congenital heart disease?
Yeah, I think being an ACHD cardiologist, I'm used to care for rather young adults or middle-aged adults. I'm not so used to care for senior adults. Mm-hmm. And what we actually have to learn as ACHD cardiologists to do, like the general cardiologist, pay more attention to acquired heart disease. And this means that at a certain point in time, at age, let's say at the age of 40, we have to think in our patients about the cardiovascular risk factors, about hypertension, about high cholesterol, about diabetes, and screen these patients with blood work specifically for these kind of problems, even if they don't have any symptoms and they feel very well. Because identifying the risk factors, I guess, is the first step to try and improve or help the patients and try to lower their cardiovascular risk.
Okay. Thank you for explaining that. And I think it really highlights the fact that we need to keep preventative approaches in mind all the time. Just switching gears to talking about research that kind of might help inform us about certain things to look out for in this patient population. Could you explain some of the challenges that researchers face when including participants with congenital heart disease into studies of acquired heart disease? And some challenges that might come up in terms of delineating risk factors? How might some of these challenges then impact congenital heart disease patients?
Well, I guess the challenge is that if in general cardiology, we do research about acquired heart disease, we have thousands or millions of patients we can include in this kind of population studies. And so we can really, just based on the huge number of patients we have, we can clearly identify also smaller risk factors or minor risks, but it allows us to have a clear picture of what's going on. And the challenge in ACHD is that even if you have more and more patients getting older, the number of ACHD patients is still very small compared to the general population. Mm-hmm. And so even if we try to investigate the risk of acquired heart disease in ACHD patients, we still have small patient numbers. And the small patient numbers gets even more difficult to interpret because we have many different lesions. And so we don't have, let's say, a homogeneous population, but we have different people with different defects in small numbers. And this makes it very difficult to identify clearly risk factors. And this actually makes the whole research much more complicated. And so far, all the evidence we have, and I said we think that ACHD patients may be at higher risk, it's not based on huge population studies, but it's based actually on reports and observations from large centers who realize that they see more and more ACHD patients showing up with a heart attack or a stroke at the emergency room. And so the awareness starts to rise for acquired heart disease. But in terms of research, actually, we're still, I guess, very much the beginning, just giving the small number of ACHD patients.
That's really interesting to know. And I think it kind of puts into perspective the fact that given that this research is largely retrospective, it's important to think about things in a preventative sense so that we're able to avoid some of these outcomes, given that we don't have as robust research as we do for acquired heart disease. Something else that I was wondering is, are there specific social determinants of health that are more prevalent in adults with congenital heart disease that might predispose them to having acquired cardiovascular disease?
Well, when it comes to social determinants, I think there are different types of social determinants. We know, for example, if you have a low social income, if you have problems in finding work and don't have low income, then it's also much more challenging to have a healthy lifestyle. And a healthy lifestyle, taking care on what you eat, taking care on how much sports you do, this is one of the things that really helps to preserve also your heart and keeps you away from acquired heart disease. On the other hand, we also know that like your mood, your optimism, or your motivation is also very important. We know that, for example, in ACHD, we have a little bit more patients having troubles with depression or anxiety, and these kind of health problems can also translate in the end into a less healthy lifestyle. Okay. Because you're less motivated or you have other troubles and you don't think about in first line what you can do for your health, because you have so many other things you have to cope with, that keeping a healthy lifestyle, eating healthy is actually less important. So I think these kind of social determinants can really play a big role when it comes into the cardiovascular risk profile. But then we also know that, like, simple facts, like, for example, smoking. Mm-hmm. Smoking is actually, in addition to hypertension, one of the most important risk factors for developing acquired heart disease. And we know that somebody who smokes has a 5-time higher risk of having a heart attack than somebody who doesn't smoke. And so this kind of just what we actually know for a general population translate into ACHD people and make you more aware of actually what are the risks, I think might be helpful in the end to promote a healthy lifestyle and to lower the risk.
For sure. And if someone is a current smoker now and they decide that they want to quit, how does that then impact their risk in the future? Can they significantly decrease their risk of cardiovascular disease? Or if they have a long-standing history, does it not make much of a difference at that point? Can you comment on how that risk changes?
I, th I think smoking is a good example. We know that if you stop smoking, your cardiovascular risk or your risk of having a heart attack will slowly decrease over time. In the first 1 to 3 years after having stopped smoking, your risk of a heart attack is still higher, but gradually it goes down. We know, of course, that smoking can more easily lead to calcification in your vessels, and the calcifications you have once in your vessel, they unfortunately don't go away. But stop smoking helps to not produce much more any new calcification, and thereby can really be helpful to reduce the risk of having a heart attack. And we also know, for example, from studies from Israel, actually the risk of an unhealthy lifestyle in terms of not eating healthy, not moving around, also being overweight, if this starts at adolescence, even if at one point in time you decide to change your lifestyle, you can change your lifestyle and have a healthy lifestyle, being overweight as adolescents is a risk factor for cardiovascular disease throughout your whole life. And of course, if you continue to be overweight as an adult, you have a much higher risk. But even if you start to have a healthy lifestyle, you still have a higher risk than somebody who actually never was overweight. And so I think the perception that the healthy lifestyle is an important investment for the rest of your life should actually start not just at adult age, but already in adolescence. And that's another thing I think we can try to improve. I know sometimes it's tough, but still we just have to try and to see what we can achieve.
I think that's a really important point to highlight because sometimes I think acquired heart disease is really framed in the lens of a disease of older individuals. But you're attesting to the fact that even lifestyle aspects in someone's adolescence can have a really long-standing effect even in the future.
Exactly, yeah.
Yeah. And you commented on the mental health piece of those with congenital heart disease and how there might be higher rates of depression or other mental health challenges. Do we know if that's directly related to having congenital heart disease or if it's just an association that's been observed over time?
I guess it's not related to the effect itself, but I think it's related to all the challenges that you have to face. Mm-hmm. As a person with a congenital heart defect. You require much more surgeries, much more interventions, sometimes risky interventions. You may be less able to interact with other people. And so I think the whole burden and the consequences of having a congenital heart defect really translate to having to cope with more stress. And not everybody can cope so easily with more stress. And I think this leads in the end to the higher burden of anxiety and depression we really can observe in adults with congenital heart disease. And this again, as I said initially, can translate in the end in the less healthy lifestyle, and the less healthy lifestyle again translate into more acquired heart disease.
Okay, thank you for explaining that. Some adults with CHD were once told to eat high-fat diets as children to help them gain weight. And this was a concept that was not communicated too much nowadays, but was in the past. So can you comment on how this messaging has changed and if this could potentially have negative consequences for these individuals in the future?
I think we really have gone far away. We have made big steps, and I think this concept of high fat and the calorie-rich diet, I think does not apply anymore to most of the ACHD people. nowadays, what we try to encourage is a healthy diet, and healthy diet means usually Mediterranean diet, and this means you have to try and eat more fruits, more vegetables, try to reduce your consumption of red meat to, I guess, 500 grams a week, and really try to avoid alcohol as much as possible. And I think with these kind of healthy diet, I think you really have a big impact on your lipid level, on your cholesterol, also on the risk of you having at one point in time high blood sugar. And this is now actually what we try to promote for most of our patients.
Okay. And in trying to keep up with some of these lifestyle interventions, is there any help or a role for primary care to help aid in someone achieving some of these lifestyle modifications?
Yeah, of course. I think having a family doctor who sees you on a more regular basis is certainly much more helpful than having an ACHD cardiologist who sees you maybe once or every second year, because I think most of these modifications, they don't happen at once. Let's say you try to stop smoking. That's not a decision you made at one day and the next day you stop. I think it's a process, and you need support. Maybe you need nicotine patch, you need supportive material. And I think this is what your family doctor can help you with. And also when it comes to doing more exercise, or let's say trying to have a more healthy diet, I think it's also your family doctor who can really give you advice and tips, or send you to a nutrition specialist who can advise you, can help you. And I think prevention is really an important topic for family doctors. And I think they actually should also be able to assist you in this respect. And because you have more easy access sometimes to family doctor and to ACHD specialist, I think they play also an important role.
Do you think that there's a role for more education about congenital heart disease across different medical specialties so that they can better inform their patients about some of their comorbid challenges in the context of congenital heart disease?
Yeah, I think the more a doctor who cares for you, they care for you, knows about your heart condition, I think the better he can advise you. And I guess here it's also a little bit our task, our job as ACHD doctors, actually to provide your family doctor or the other specialist you need with the necessary information they need to make actually informed decisions, or to advise you, or to consult you on what's going on. So I think we should try in our letters to the other doctors, not just to summarize the main findings of your last echo, but also to give some advice on how they can support you and what might actually be important when it comes to other medical decisions.
Thank you. That's really helpful. And if someone has congenital heart disease and they're wondering how often they should be getting an echo or an ECG or getting some more specialized testing in cardiology, what kind of advice would you give them?
Well, I think when it comes to the congenital heart defect, and I think your ACHD doctor is the best who knows on what kind of testing, what kind of interval is actually needed. And I would ask him. And it's also that there is no fixed scheme that we can apply to all patients. I think every patient has an individual lesion, and some lesions may be more cured, or let's say may have less issues and have more issues. And so it's not only what kind of defect you have, but also how the result from the last surgery now affects your heart, which determines how often we have to see you. And so I think the interval on what kind of test we need is actually really dependent on how you're doing. So there's no fixed scheme. And I think also every ACHD doctor may do it a little bit different. So if you are followed once in Toronto, once in Ottawa, maybe once in London, you will not always have the same scheme of testing. It's just based on the experience of your ACHD doctor.
That's really helpful. And I think a common theme when talking about congenital heart disease is that everyone is so different, and things can often change from person to person. So I think it's good for everyone to keep that in mind. If someone's looking for more resources and they want to take some more control over their health, what kind of resources would you direct them to in order to be better informed about some of these topics?
I think I would first ask your family doctor and your ACHD doctor. And I think the second resource, there are medical associations like your Alliance, I think, and I think they can provide additional information, also not just the congenital cardiac defect, but also to a healthy lifestyle. And there's also websites like Heart and Stroke, which provide medical information, not just for all kind of cardiology patients, also including ACHD patients. So I think if you would like to have more information, I would ask your doctor. And I would also turn to official websites of medical alliances and also Heart and Stroke and see what you can get there. I think if you go on Google, then sometimes it can be challenging to distinguish between what is useful and less useful. And in the end, you may be more stressed than before.
Yeah, and I think that's especially important in the context of CHD because there's often not a clear answer that will fit everyone that Google can generate for you. So I think that's really important advice.
Yeah.
Well, thank you so much for joining us today and providing your insight on acquired heart disease.
It was a nice talk. Thanks a lot to you for giving me the opportunity. It was a pleasure.